Good afternoon, everyone. Very welcome to the BAUS session. Wow, right. I'm Nikita. I'm one of the co-chairs for BAUS, and this is
Sinan. I'm the other co-chair.
So we're going to start the session by playing a short video from Viru. So can we play the first recorder you have, please?
Greetings from sunny Melbourne. My name is Viru Kasikis-Vanathan, and it's with great pleasure.
Oh, hopefully we'll get some pictures of it. There we go.
Greetings from sunny Melbourne. My name is Viru Kasikis-Vanathan, and it's with great pleasure that as Director of the BAUS Research Collaborative, I can introduce this session to you. I wanted to give great thanks to the committee who are distributed around the UK, who have contributed tirelessly to the hard work that helped us achieve presentations, publications, and prizes around the world. Most importantly, I'd like to thank our collaborators who have helped to make all of the work we have possible. Thank you. So I'm going to present 5 highlights, which I want to draw your attention towards from the work that BAUS has been doing. The first is the publication of the Identify study in the British Journal of Urology International. This looks at the prevalence of urinary tract cancer across patients with different risk factors and geographical locations. It was featured in the BJUI's first webinar and also has a lot of attention around social media. Now, hopefully with this, we can produce the risk calculator, which is a paper in submission, which you as clinicians can use to risk stratify patients referred to you with suspected urinary tract cancer, so you can decide whether and how to investigate. Second, I wanted to highlight the LEARN study. Now, I think you'll all agree that being able to ensure that doctors around the world and around the UK, no matter what specialty they end up going into, need to have a certain minimum requirement of urology knowledge. And also, I think it's critical that we ourselves strive to get the best doctors into our specialty to ensure our specialty lives on. LEARN study looks at medical students from every single medical school across the UK and highlights areas for development and highlights the exposure that medical students have. And with this information, we'll be able to lobby medical schools around the country and work with BAUS to produce a syllabus which can be updated for undergraduate education in neurology. Third, so BAUS and BURST together have produced a national consensus called FIX-IT on what you do during a scrotal exploration for suspected torsion. So once you open up the scrotum, there are a number of decisions you have to make for what is one of the most common emergencies we face. What happens if there are unexpected findings? When do you fix the testis? What materials do you use? These are all questions that are answered in our consensus meeting, which will hopefully be published in print by the time this is aired. 4. So now we have the RESECT study, which is a study that Kevin will be speaking about later, but I wanted to highlight some of the innovative aspects of it. This is a prospective audit, but within that, there's embedded a randomized trial of audit and feedback. Now, this is a really novel way of seeing whether if we have the outcomes of our surgeries, we can actually go on to improve how we perform them and our patient outcomes. And I'm very pleased to see that we've recruited just under 10,000 patients. The last thing I wanted to mention was the 2 clinical trials which we have in development, the RESIST study and the RESCUE study. Now, these are both clinical trials which can hopefully change practice, for which we have collaborated with the CHART group from Aberdeen. RESIST is looking at uncomplicated ureteroscopy and whether or not we perform ureteric stenting after that. And RESCUE is looking at whether or not we can use ultrasound to influence who we take to theatre for suspected testicular torsion. Hopefully we'll be able to give you more updates on those in the coming year. So on that note, I would like to hand over to our fantastic co-chairs, Nikita Bhatt and Sinan Kaduri, who will introduce the rest of the session to you. Thank you, and hopefully see you soon.
Good afternoon, everyone. I'm Nikita, and with Sinan, I'll be co-chairing this session today. Thank you very much for joining us this afternoon, and it's lovely to see everyone face to face. So Veer has already alluded to our studies, and since our inception, we have completed 4 studies. I like to think of our studies as gifts that keep giving, and these have produced several high impact factor journal publications, presentations, prizes all around the world, and secondary projects that I'll come to in a minute. Many congratulations to Mimic, Identify, Learn, and FIX-IT, who've all published papers this year. So that's amazing. With Mimic and Identify, we've been able to produce 2 risk calculators. For Mimic, we've got the stone expulsion calculator, and Identify is the risk calculator that Sinan will talk to you about. And the beauty of this research is these are results that you can actually use in your practice while you're at work, in A&E, or in clinic. So today's session is going to focus on our current studies, and these include RESECT, COVID Surge, RESCUE, and RESIST, and hopefully you'll be able to differentiate between all the R's by the end of the session. We also have an amazing debate among 2 stalwarts here that promise to entertain, so stay tuned for RESIST. And for RESCUE, we've got a hands-on training model at the back of the room for some POCUS training, so stay till the end of the session if you're interested. So finally, how you can get involved with us. We're always looking for study recruiters, collaborators. If you like what we're doing, please help us out. Our studies will not only help you with PubMed Index collaborator authorship, they'll help you towards your CCT requirements. And I think most importantly, this is research produced by trainees, used by trainees, and that does change practice. So we're quite proud of what we do. Sinan will talk to you about the remaining. And I'd also like to mention our education involvement. We're heavily involved with BJUI knowledge, and we've produced a few modules on statistics and research methodology. So if you're interested or trying to learn about this, these are available free of cost on BJUI knowledge if you're a BAUS member. We also manage Trainees Corner with BJUI and BJUI podcasts. So if you're interested in submitting to either of those, please get in touch with us. And with that, I'm going to hand over to Sinan.
Thanks, Nikita. So a common question to us is always, what's next for BAUS? What BAUS, leading on from all their success? Well, as Nikita alluded to, we're looking at trials now, and we're more and more looking at interventional studies. I'll also be talking about a different education series we'll be doing, and finally committee recruitment and how you can be more active within BAUS itself. So we're always looking for new research ideas. So if you have one, I'll show you how you can send a proposal over to us through our website. But we are looking more and more at interventional practice-changing studies rather than audits, although they have their place as well. So if you go to our website and click on opportunities, and then this isn't working very well, but then at the bottom there's a little link which takes you to our project proposal pro forma, and that'll just help you to outline what we would want to know in your project idea and really hone in your research question before you contact us with that idea. We are looking to do an education series where we will summarize key papers, so a string of key papers for different topics in neurology, and as a structure base, we'll use the FRCS exam syllabus. It's not for the FRCS because you don't need to know all the papers to pass that, but that will be the syllabus we'll be using. So that's a big ongoing project that we will probably be looking at someone to come in and help in our next recruitment round, which takes me on to the next slide. So we're looking at recruiting new members in November. So if you are interested, make sure you've got our newsletter, you're subscribed to our newsletter through email, and you follow us on social media. We'll be looking at positions for 12 to 18 months for a general BAUS member. Things that we tend to look out for are people with IT skills, graphic design, education, interest, again, what I was talking about with our series coming out, and project leads that want to lead on their research ideas. And of course, we always encourage medical students as well. So we'll be recruiting wonderful medical students to lead their own projects and also help in existing ones. That's our contact details. Finally, again, to reiterate what Vera said, thank you to our committee who work really hard, and all our collaborators as well, without which none of our projects would be possible. Thank you to our sponsors as well. And I think without further ado, we'll proceed with the program.
Thanks, Sinan. So I'm now going to, we're going to play a recording with our guest speaker that Aqua, one of our committee members, has interviewed, Reena Malik.
Hi everyone, thank you for tuning in, and it's a pleasure to welcome Dr. Malik. Do you want to introduce yourself?
Hi, thanks so much for having me. So my name is Reena Malik. I am an academic urologist in the United States. I practice in University of Maryland, and I am subspecialty trained in female pelvic medicine and reconstructive surgery. And I kind of wear two different hats now as a urologist. I'm an academic, so I publish research. I work with residents, and I'm very involved academically, involved in our subspecialty societies, as well as being online content editor for the Journal of Urology and the Urology Practice Journal. So from that's my academic hat, and then I also have a kind of, I guess, online brand where I make urologic educational content on YouTube and multiple other social media platforms to educate the general public on urologic health, sexual health, and anything in between. And so that's a little bit about me.
Okay, thank you so much. And I guess you've pivoted to my next question. And because of your social media following, and you've done so well on this, you've got more than 1 million subscribers now. And it's amazing that you're using your platform to amplify your messages. What, I guess, motivated you to start it?
Yeah, thank you. So it's been a journey. It was not something I ever intended on doing. I started because I had this passion for education. So when I was a resident, I recall, during training, we did a very complex, we did an Indiana pouch on a woman with bladder cancer. And she kept getting readmitted for metabolic acidosis, going into the ICU over and over again. And ultimately, we realized that she didn't have the basic understanding that she needed to catheterize her pouch, right, in order to live, like to catheterize regularly. And so that was a real light bulb moment for me where I realized we can do the perfect surgery. We can do everything right. But if the patient doesn't understand what they need to do afterwards, what the risks are, what the complications are, you're going to have an unhappy patient. And so that's when I got passionate about health literacy. And, I started really delving deep into that and realized that I'm definitely going to continue doing research in that, but I wanted to start right away. I wanted to do my part in educating patients. And so I started, on social media, just on Twitter, like most young academic, urologists in training, and started, just interacting with the urology community, tweeting about my research, learning about other people's research, making networking on social media, and then did it for our subspecialty society, SUFU. And so I got really involved in it. And then I said, okay, let me try some other platforms. So I went to Instagram and then ultimately went to YouTube and said, I'm just going to try this. I'm just going to try to make video content and see how it goes. And it's been a great journey because I've been able to reach people from all over the world and make a difference in their lives just by offering education. So it's been really impactful and really meaningful.
Amazing. Okay. And then my next question kind of goes along with that. How did you, because, a lot of us do that already. How did you in particular grow your brand, very successfully?
Yeah, I think there's a lot of factors that go into it, but I would say the number one factor is being consistent, right? As a physician or even someone in training, you're very busy, right? You don't always have the time to dedicate, and you can lose time very easily by scrolling social media or by stressing about how perfect something looks. And I think you just have to rip off the Band-Aid, do it consistently, and then listen to what your audience wants. So whatever platform you're on, you have to kind of get an idea like what content does well, and then keep making content that's like that.
Okay, and I guess, again, you're leading to all my questions. With the audience aspect, especially on YouTube, I guess, have you faced any barriers or any negative comments or, following because of some of the content that you've made?
Of course. I mean, you can't be on social media and not get negative comments or creepy DMs in your inbox or whatever, right? So I think you have to have some thick skin and you have to be 100% behind what you put on social media. So if there's younger people listening, be very careful. No HIPAA information, no patient information on social media. Don't make fun of colleagues. Don't make fun of co-residents. Just be very professional. Whatever you're putting on there, it's there forever. Even if you take it down, it gets copied and pasted onto different platforms and things. And so you just have to think about what you're putting out there is how you present yourself. And as long as you feel 100% proud of what you're putting out there, there's no problem at all in doing this, as long as you feel comfortable with it and not letting those people get to you.
Okay, I guess this is going to be more of a personal question, but do you have any vivid experiences of, something both positive and negative throughout your social media journey?
I would say positive, so many. I mean, I get messages every day about how people tell me they're so grateful for my content. I've changed their lives. I've had patients come to me and tell me how thankful they are for my videos and, how much they watch them and how much they use them day to day. So that's been extremely positive. As far as negative, I can't say there's been much negative that I've let stick around. Like, sure, there's plenty of negative, but nothing that I can even remember because I don't waste any brain space on it.
One of my, I guess, pressing questions that I really want to, get out of you today is, how would you, I guess, advise us to combine both of our social media and our work to form one unified message?
So I think to form a unified message, you have to know what that message is. So it may be different for one person to another, right? Like for me, it's education. For you, it may be amplifying your research. For another person, it may be connecting with other urologists or other professional folks. And so depending on what your goal is how you craft your message and where you send it. So you may not be good on camera, and that's okay. Maybe you shouldn't make videos. You may not like taking photos, and that's okay. Maybe you shouldn't be on Instagram. But you got to pick your platform based on what you're good at and what you want to do, right? It shouldn't be a job. It shouldn't be something you already have a full-time job. It should be something you enjoy doing. So I think it's really important to spend that time and do some introspection on, one, what's your message? What's your purpose? And two, what platform are you going to enjoy being on? Because you'll spend a lot of time on it if you want to build something. And so those are the two key things. And I think it varies person to person. There's no one right answer.
And I think from, I guess, my own personal observation, it seems like a lot of urology researchers are using Twitter. What top tips would you give for your average Twitter user to, I guess, boost their engagement?
Yeah, so I think you have to go on Twitter. You have to comment on people's stuff, retweet, like stuff. And in the beginning, that's all you have to do, just like and retweet if you don't know what to say. But ultimately, you'll find your voice. You want to make commentary on the things that you see. You can retweet a popular post and say put your thoughts about it, on the post. So those are ways to interact. And then when it comes to like boosting your own information, and you want to do that cautiously, right? I don't post every paper I write on there because I think it's a little boastful. So I think, you want to do it sparingly, but when you do it, you can be impactful about it. Like you can do tweetorials, which are, tweet threads where you write a tweet and then you write replies underneath it. And in those include some graphics or paper, some of the paper, like some of the actual figures or tables from the paper, or if you want to spend the time, you can actually make a visual abstract. And there's great resources online on how to make a visual abstract. They don't take that long, and they can be really great ways to represent your data in a visual way that people will remember. And there's great data to suggest that people actually remember papers that they've seen on visual abstracts better than they do other papers. And it helps with amplifying the message, as well as even potentially alt metrics and citations down the road. So it's worth the time and effort if you've put a lot of time and effort into a project to actually spend the time doing that. And if it's not for you, you can have your medical students or residents or trainees do that as well. And they'll get something out of it as a boost for them when they're applying for residency or applying for fellowship, things like that.
So, Dr. Malik, you're obviously a full-time clinician as well as a social media user, and so you wear multiple hats. How do you, I guess, manage your time doing all of that?
Yeah, so you have a community of people to support you, right? And certainly I have support at work with my nurses, my staff, and when you're at work, you're focused 100% there. But then it's about managing your free time. So, I know that every week I'm going to record a video, and I'm going to, and I need time to do that. So, my husband is extremely supportive. He helps with, watching the children and doing the other things while I'm doing those things, completely very supportive. And then as you grow and you become busier or bigger on social media, you can hire help. Like you can get a virtual assistant or an editor, things like that can help expand your availability and your time. And I think you just have to think if this is a priority, it's just like anything else. It's like writing a manuscript or writing an abstract, whatever it is, you're going to get it done because you've now made it a priority.
Okay, and I guess to wrap up, do you think you can tell us 2 or 3 top tips for any urology researcher?
Okay. Top 3 tips for any researcher. That's a tough question. So first one would be, don't let the projects go. Like don't let them linger too long, right? So make sure that with any research project, you have deadlines for yourself, for your team, and you just keep going and make sure you see the project to the end. And as we all know, it's so many rejections before you get a success, whether it's grant funding or manuscript writing. It can be really trying. And I think you just have to think of every failure as another step towards success. And that's important. Like when I started as an attending, our interim chair, our Department of Surgery chair said, I think for every 10 grant applications, I got 1 funded. And that was so telling to me. So now when I put a grant application in, my expectations are low, which is good. And 2, it allows me to just keep going. Like I need to submit 10 before I get 1 sort of thing. And so it helps kind of have that perspective. Number 2 is absolutely, raise up those juniors below you. Like for me, my goals are always to get my students and residents to be first authors and get a publication under their belt, get something to support them. I'll even include them on smaller publications. Like we have the AUA News, like, why don't you write this AUA newsletter? And I'm happy to help you. So that's always really meaningful to me. And I think really great for any researcher to be able to allow to teach people and give people their skills and help them learn from you. And I have students all the time who match in different specialties. And I just got an email today, for example, where one of my students matched in medicine and she was just so thrilled. She's like, you were so instrumental in helping me get here. And it's really meaningful. And lastly, I would just say, amplify your work, right? Like you did all this work. We spent a year plus 2, 3, 4, 5 years, whatever it is on that particular project. And so it deserves that little extra push, whether it's posting it on social media or talking to your press team at your institution and be like, can you try to get this in the press, whatever it is, but push for that because you've spent all this time. Now spend that extra few minutes to try and get some more eyes on your work.
Thank you so much, Lisa. It's been a pleasure having you. Yep.
Thanks for having me.
Okay. Thanks to Dr. Malik. Obviously, she's in the US, so she couldn't be here, but that was really insightful interview into social media and how it can be used. And thank you to Aqua who interviewed her. Thank you. So next, I'd like to introduce Arjun to come up and talk. He's co-vice chair of BAUS, and he'll be talking to you about the COVID surge follow-up study and the 1-year outcomes.
Thanks, Inan. Hi, everyone. Like Sana said, I'm Arjun. Nice to meet you all. After that very inspiring video, I'm going to sort of drag you back into the pandemic times, unfortunately, but only very briefly, and hopefully we can learn some lessons together about what happened and how to take things forward. So this is a project that we did with the COVID Surge Collaborative, using a lot of data around the world to try and identify risk factors and patterns of disease during the pandemic. And that really, they played a big role in helping us manage the acute situation. And I think that saved a lot of lives. And this is a follow-up study that we did with them, looking at urology cancer in particular. So as you know, huge disruption during the pandemic, and COVID Surge mobilized really quickly to get great quality data out there and really influence practice and the guidelines. And what we wanted to find out after that, the follow-up study to that was, is it safe to perform elective cancer surgery? And if it is, where is it safe? So I'm sure you all were aware there were hot, cold sites and what worked, what didn't work. And we specifically looked at the 3 sort of big cancers in urology, prostate, bladder, and kidney over the sort of peak times during the pandemic. And we tried to identify risk factors. And this is the first part of what I'm going to talk to you about. And later I've got some more interesting data, but this is sort of an overview of what happened during the pandemic. So you guys know this is the data that you experienced. So we looked at 2,000 patients across the world, 36 countries, a good split of urological cancer between those patients. And as you'd expect, if you had a concurrent COVID infection, you were more likely to get a major surgical complication, more likely to get a respiratory complication, and more likely to die, unfortunately. Now, this data, gladly to say to you, I'm glad to say, is actually out of date now because we have vaccinations, we have new variants, and fortunately we don't have these kind of rates of complications and mortality anymore, which is great. However, we do have another problem, and that is there were patients that were supposed to be operated on during the pandemic with urology cancer that maybe didn't get an operation. And this gave us an opportunity to look at these patients from a sort of epidemiological point of view. We would never do it normally in the trial. We never say to a patient, here are the guidelines, you're supposed to get an operation within X amount of time, but actually we're not going to do that operation. We're going to see what happens to you. But actually this situation gave us an opportunity to look at those patients. Do these patients need surgery immediately, or can they be delayed? So very, very hot off the press. And I mean, the analysis came through on Friday, and I did this presentation this morning. We have the results for prostate cancer. So if you remember, prostate cancer, out of the 3 cancers, probably the most indolent. The recommendations at the time from the NCCN was you can delay all prostate cancer surgery during the height of the pandemic. EAU expert panel said you can delay most of it, but high risks should still be prioritized to get a radical prostatectomy. Why is that relevant now out of pandemic times? Well, there can be some benefits to delaying surgery. Now there's a plethora of different options for patients when they have prostate cancer in terms of their treatment options. There's new focal modalities coming into play, and you need to be counseled appropriately. So it's not just active surveillance, see a surgeon, see an oncologist. There's all types of different modalities that can also be used. So giving a patient the appropriate information is really important, and that takes time. And they also need to go away, they need to consider their options, then come back to you, feeling that they've made the right decision and feeling like they're not going to regret this decision. And also logistical pressures, waiting lists, especially places like America, long waiting lists, and can it ease the pressures if you can delay surgery? So we looked at just the prostate cancer patients, and we sort of said scheduled is within 90 days of the MDT decision to operate, and then delayed is after 90 days. And we followed them up for the first year, so now we've got a 1-year outcomes. What we saw is, 476 patients met the inclusion criteria, 65% scheduled, so they had their operation within the 90 days from the MDT, 35% delayed. So quite a good amount. We thought that we were probably going to see more younger, fitter patients operated on just because of the risk during the time of complications, but that wasn't the case. They weren't prioritized overall across the world. But as you would expect, the high-risk patients were prioritized. So out of all the high-risk patients, 73% did have an operation within 90 days, but actually still a good amount didn't. And this use of neoadjuvant ADT, so you can give hormones. It's sort of slows down the progression of the prostate cancer. This idea it sort of buys you time, but actually that wasn't used across the world. I know locally it's probably used a bit more, but that wasn't a strategy that was employed across the world. So we also thought, if they take you back to time when people were putting ports in and doing some laparoscopic surgery, they were all very concerned about pneumoperitoneum and disseminating COVID. And we saw that there was more open surgery during the actual pandemic. For those scheduled patients, they were having more open surgery, so they weren't getting robot-assisted laparoscopic as much, and they were getting open. I think that was because of those concerns regarding creating that pneumoperitoneum. And there's more consultant-led surgery for those delayed patients. Maybe they just thought they've been waiting, maybe they've upstaged, we need to change the operative plan, consultants should do this rather than the trainee. And there were actually more complications to the scheduled patients. Maybe that's because there were more open surgeries being performed. That might be why there's a higher complication rate. And a lot of those surgeons wouldn't have been doing that much open surgery. They would have been robot surgeons that then converted back during the pandemic.
1 minute left.
So just really quick, this is important stuff now. So these are the oncological outcomes. So that question I put to you, does it actually impact them if they have delayed surgery? I'd say yes. So if you have a delay to your surgery and you're due to have a radical prostatectomy, but you wait by more than 90 days, your biochemical recurrence rate is 18% versus 9% if you have it within the first 90 days. Your margin rate is the same, but your upstaging is also significantly greater, and your upgradation is the same. So those are really novel results, because all we've ever looked at before is active surveillance versus radical prostatectomy in retrospective cohorts, but this is prospective data in an international setting that's shown against all the evidence that is out there that if you wait, it's not that safe, because the oncological impact is actually quite significant. So just to summarize, quite a considerable number of patients didn't have surgery within 90 days. 7% of patients went on to have some other form of procedure, so radiotherapy. They never even went on to have surgery, even though the MDT recommended it. the oncological outcomes are not the same. And I'll put it back to you. If I were to tell you, you've got prostate cancer, we think, and we agreed together, you should have a radical prostatectomy, would you want to wait 90 days, knowing that you are twice as likely to suffer biochemical failure within the first year? I wouldn't, but you can make your own mind up. And just to let you know, we've also done this with kidney and bladder. We are getting those results in sometime soon, and we'll be presenting those as well next year. So we'll see what it's like for kidney and bladder cancer as well. Thank you very much, and thank you to our sponsors and supporters.
Thank you, Arjun. You can put questions on the chat, or we can ask them at the end, just in the interest of time. I'm going to invite Alex Light next, who's our comms lead, and he's going to talk to us about Fix-It, who've recently published their paper, so congratulations.
Hi, everyone. My name is Alex. I'm a core trainee from London, and I'll be presenting Fix-It, hopefully. I was one of the co-leads for Fix-It. So Fix-It was a national burst BAUS consensus guideline for the conduct of emergency scrotal exploration and suspected torsion. So imagine you have a young guy, several hours of severe testicular pain. I think we'll probably agree we want to take this chap to theatre. The rescue team might disagree later, but we probably want to take this chap to theatre. But what we do in theatre next, we actually tend to vary quite a lot. What if you want twisted torsion, but the testicle still looks a little bit patchy? What do you do? If you decide to fix the testicle, what technique are you going to use? We know from the literature there are multiple techniques out there, but none of them actually have any clinical data to support their use. We also know from surveys that UK surgeons tend to vary in their orchidopexy technique, and I'm sure you might have seen that at work as well. And we also know that there are no national or international guidelines to guide either the conduct or technique of scrotal exploration and fixation. So the aim of Fix-It was to create a national UK consensus guideline between BURST and BAUS to act as a reference standard or a guide at least for the conduct and technique of scrotal exploration and fixation. And I'm delighted to say that very recently this was accepted for publication by the BJUI, and as of Friday, last Friday, you can view the unproofed version online. So I recommend everyone have a look at this afterwards. I'll go through some of the key recommendations. Just briefly though, so Fix-It was a 2-round consensus exercise. We involved 16 urologists across the country from different subspecialties, and we scored 200 statements spanning 10 different categories. Broadly, these range from consent all the way through to things like logistics and follow-up as well. And importantly, they are based on the decision that the decision to operate has already been made at that point. Just for the sake of time today, I'll just go through the intraoperative decision-making and the fixation recommendations as they form the bulk of our discussions. So for intraoperative decision-making, we split this into 3 scenarios based on what you find intra-op. In scenario A, torsion confirmed. So you found a torsion as you suspected. And first, as I'm sure most of us do already, if you think the testicle is viable, we recommend untwisting it and then fixing both sides. But what if the testicle looks a little bit ischemic? In this case, we recommend untwisting it and wrapping it in saline-soaked gauze, warm saline-soaked gauze, and keeping an eye on it to see if any perfusion returns. And we recommend that the time it takes you to then explore and fix the contralateral side is how long you should wait for this. So after you've fixed the contralateral side, come back to the ipsilateral testicle and re-inspect it. If it's viable, then yes, we recommend fixing it. If it still looks a little bit patchy, a little bit ischemic, and you're still not sure, we recommend at this point performing a stab incision of the tunica albuginea to see if there's any bleeding. And if you're still unsure after that, then we recommend fixing it anyway. And lastly, of course, if the testicle has infarcted and is dead, then an orchidectomy is warranted. In scenario B, the testicle appears normal, there is no torsion, there is no other pathology. And at this point, decision-making will revolve around the presence or absence of a bell clapper deformity, which you can see here on the right. So importantly, if there's no bell clapper seen ipsilaterally, we recommend do not perform fixation. We recommend simply closing at that point and finishing the operation. However, if there is a bell clapper seen, we recommend fixing that side, and we also recommend exploring the other side. However, only if the other side has a bell clapper would we recommend fixing the other side. So again, it kind of revolves around a bell clapper in scenario B. And the final scenario, scenario C, is when there's no torsion, but there's another pathology, for example, epididymoorchitis. And again, decision-making revolves largely around a bell clapper deformity. If there's no bell clapper, as before, recommend simply replacing the testis and closing. If there is a bell clapper, however, then regardless of the pathology, so even if there's infection, we recommend fixing the testis at that point. Now, what you do next depends on what the pathology is. So if it is epididymolycitis, at that point, finish up and close. Do not explore the other side. However, if it's any other pathology, then we recommend exploring the contralateral side. And as before, if and only if there is a bell clapper contralaterally, then fix the contralateral side as well. And just briefly on fixation, so we recommend that in children, both sutureless and sutured fixation techniques are acceptable, but in adults, we only recommended performing sutured fixation. And for this technique, we recommend is to use 3-point fixation using non-absorbable sutures like proline, placed on the lateral, medial, and inferior surfaces of either pole of the testis. Alternatively, using a 4-point fixation and material like PDS would also be acceptable. So just to quickly summarize, Fix-It has been a long-running project for BURST. I remember we started this just before BURST 2019. So it's very good to see this come over the line. Thank you very much to all of our BURST team and BAUS, as well as our panelists you can see here. We hope that these guidelines form a good reference for the conduct of scrotal exploration, and I hope you enjoy reading them in the BJUI, who we thank for supporting all the work that BURST does.
Thanks, Alex. Right. So we'll have questions at the end then.
Yep. So now I'd like to invite Kevin, one of our senior committee members and RESEC lead, who will give us an update on the largest TURBT study ever performed.
Just wait for my slides.
Are there any questions about any of the other presentations whilst we're waiting for those slides to come up? No? Nothing online. I think we're almost there.
I was just talking before the session about how I'd like to be good enough to give a TED talk one day, but I'm not sure I handle it today without any slides.
There we go.
Thank you. Are speaker's notes coming on the small screen? Possibly not. Well, hi everybody. Delighted to speak to you all today in person about the RESEC study, give you an update and cover some study business. Massive thank you to all our study funders and supporters, without whom the study would not be possible. Also a massive thank you to the huge team that works behind the scenes to make this study possible, and the 1,400 individual collaborators across the world who are contributing data. Since I realized that probably quite a few of you today are actually collaborators in the study, most of the talk today will be spent covering an update on the progress and a little bit of study business, but I'll move on to talk a little bit about some concepts behind the innovative design in the study, and also then some early study data for you at the end. I won't spend too long speaking about the background of why we did this study, but it comes down to the fact that we suspect there is variation in the quality of surgery performed across the world. There is evidence that this impacts outcomes, and some evidence that auditing this might be able to improve it, but no solid evidence proving that yet. In 2020, there was a burst of interest in TURBT as the neglected procedure. The health economic and patient quality of life cost of non-muscle invasive bladder cancer is undeniable. We're very aware in designing the study that publication of surgeon outcome data can be a bit of a minefield, and we were very clear from the beginning that we would not be publishing publicly named surgical outcome data, and went to great lengths to design the study appropriately to address this. There is evidence in the literature that audit and feedback can have a significant impact on patient outcomes, but this is very situation specific. In 2020, there was a big editorial in the BMJ saying that the potential of audit and feedback to improve patient outcomes has been underutilized, and innovation and imagination was needed to bring this in to have its full effect. So BURST took on the mantle for TURBT. The primary objective of the whole study is to determine if audit and feedback can improve the quality of TURBT, but also the early recurrence rate of non-muscle invasive bladder cancer. And so in the vein of innovation and imagination, we aim to launch audit and feedback into the digital age. And so far, having started at the end of 2020, we've some major achievements behind the study, with recruitment numbers, as well as this year being presented at all major conferences right across the world. So in order to achieve that objective, this is the study that we designed. Almost 400 hospitals registered and completed a survey about their usual practice for TURBT surgery, and they're now submitting retrospective data about cases done at their hospital before they joined the study, so that we have a baseline control with which to compare to. And over 210 sites are halfway through that process already. As Vera mentioned, there's an embedded cluster randomized trial here where half of the sites will be randomized to have feedback straight up after the retrospective phase, and the other half will receive their feedback after proceeding with the prospective phase. And therefore, there'll be a robust comparison made between sites to determine what the effect of that has been. The primary outcome is the achievement of 4 TURBT quality indicators, and the secondary outcome is the early recurrence rate of bladder cancer. Recruitment has been phenomenal. Thank you to everybody who's contributing. Almost 10,000 cases in the study so far. The big challenge now is the prospective phase. 1,000 patients in the prospective phase so far, but we need everybody to get on and begin collecting their prospective data. Sites from right across the world, 102 from the UK, which is an amazing representation of British urological practice. Nobody's quite sure how many urology units there are in the UK. I believe it's about 120. So that is, a huge proportion of the UK urology units. We should all be very proud of contributing to this effort to improve our practice. So I'll spend a little bit of time just looking at the UK leaderboard. Edinburgh leading the way, Paramariappan and team there with the most cases. But interestingly, I just want to emphasize the importance of getting on to the prospective phase and beginning the prospective data entry, because some of these big total case recruiters are still waiting to start the prospective phase. The cases are accruing, they're in the bag, the data just needs to be entered. Just looking at the top recruiters misses some other phenomenal efforts from UK sites who have done the retrospective phase efficiently, moved on to the prospective phase, and are already contributing great cases in the prospective phase. People like Samuel in East Lancs and Piyush in Coventry, progressing very well with the prospective phase, so very well done. So we're on track for our timeline targets. We have 168 sites randomized so far to either receive feedback or have delayed feedback, with aiming to have the last cases in by the end of November. If you think you're going to have trouble with this deadline, please get in touch. Email us at any time, resect@bursturology.com. I just want to mention briefly that with changeovers coming up in the autumn, please plan ahead for this if you need somebody to continue to study after you leave. I want to spend a bit of time now just looking at the design of the feedback and education intervention that we have designed for TURBT surgery. So this is the Resect feedback dashboard. I won't spend a lot of time going through each component individually, but I wanted to say a few things. Firstly, it is always anonymous. Your surgeon identities and your site identity will never be revealed, and only you will be able to see your site identified on the dashboard. It was designed in close collaboration with implementation scientists and behavioral psychologists, and so has been carefully put together to achieve its purpose. The final thing we wanted to say is that We had a lot of debate about how we should address case mix differences in comparing the performance of TURBT surgery, particularly with things like the detrusor muscle. And we settled on the fact that we're never going to be able to get into the nuanced decisions about what dictates why you do these things in individual patients or not. The dashboard provides broad population comparisons and then hands back the self-reflection of what is appropriate or what is not appropriate to the individual teams. So unlike some of the other national audits, we provide this ability to go in and seamlessly link directly to the cases that actually make up that outcome for your site. So you could maybe say, oh, we haven't got the target for detrusor muscle resection. That's because we have quite old patients with low-grade tumors, so it's justified. And you could go and look and see whether that's the case. And see here, for instance, the first case is a 60 to 64-year-old who's had a moderately sized high-grade tumor and no muscle. So potentially, probably, they should have had muscle. And you can check that yourself. The idea is that the team is their own judge, and we hand that ability to review the cases back to the teams, and hopefully in that way foster an atmosphere of self-reflection in the departments at the team meetings where they can review this performance. I'll spend the last couple of minutes just talking, showing a few of the results that have come out of the study so far. The point of the study boils down to three simple questions. Is there variation? Does this impact outcomes? And can it be improved with audit and feedback? And we've already answered the first question. There is significant variation in the quality of TURBT surgery within the UK and across the world as judged by these four quality indicators. Won't look at this in detail. It's going to be presented in abstract on Wednesday, but look at the spread of data points on the graph there. There's a huge spread in the proportions achieving each one of these indicators. This is some data which has not been presented before, and it is a preliminary analysis, so it has some caveats which are listed here on the left. But I wanted to begin to make that link between variation in quality or performance of some of the indicators of quality of TURBT surgery and clinical outcomes, such as the early recurrence rate. This data is descriptive only, it's unadjusted, and it will allow us to begin to ask the question of why there's variation here. So this shows the early recurrence rate within 6 months after a first tumor TURBT surgery for high-grade and low-grade tumors. And you can see that the bulk of proportion of recurrence for high-grade is somewhere between 10 and 40%, quite a wide range, I would say. And for low-grade, somewhere between 5 and 30%. With the medians about what we would expect from published literature. We don't know why this is at this stage, but with the RESECT study and the amazing granularity of the data that each one of the collaborators has been collecting is the only way that we could ever be able to answer the question of why is there this variation? Is it really down to case mix, tumor size, tumor number, or are there other factors at play here? And can we influence them? Can we make it better? Could we have every site achieving 10% recurrence rate in early recurrence for high-grade tumors or 5% for low-grade, because the benefit of that when applied at scale would be huge.
1 minute.
So, wherefore RESECT in the future? Well, we've already shown that there is significant variation in practice, quality, potentially in early recurrence rates after TURBT surgery across the UK and internationally. We'll find out soon if that is impacting the recurrence rates. And finally, we will hopefully prove that audit and feedback can improve it. Is there a case here for a continuous national audit of TURBT surgery? And if so, the patient and health economic impacts could be huge. And once again, I just want to say a huge thank you to all 1,400 of our study collaborators who've been doing amazing work. Thank you.
Thank you, Kevin. We might have time for just one quick question, if anyone has a burning question. Otherwise, we will move on.
Okay, then. So I'll now invite Kevin Burns on stage, who is co-lead for Resist, formerly Stent, previous year's Dragon's Den winner. And with him, Mr. Darren Smith, who will be also talking about RESIST. He is co-PI for the NIHR application, and they will introduce the RESIST debate.
Thanks, Nikita. So I'll get things started in this debate by giving a short introduction on what the RESIST trial plans to be and what we hope to achieve. The research question that we're trying to answer here is stenting necessary after uncomplicated uteroscopy or flexible uteroscopy? What do the guidelines say? Well, NICE guidelines give a very nuanced statement, and they say do not routinely offer post-treatment stenting. When we look into the evidence, a recent Cochrane review, which reviewed 23 RCTs, 2,500 patients, was very uncertain about the key outcomes of pain, post-operative readmission, and re-procedure. The bottom line of that Cochrane review is that we now need a large, well-conducted RCT to better inform practice. Previously, we performed a large survey of over 300 urologists, and we asked them about their current practices on this topic. We found that urologists were most concerned about the development of postoperative obstruction. And with this in mind, 92% still insert stents in uncomplicated cases. Despite this, and reassuringly, 81% report equipoise to randomize to either stent or no stent. And that means that an RCT in this area is feasible. Why do we need an RCT? Well, we can clearly see from guideline recommendations that we need more evidence to be able to better inform our practice. Remarkably, in that Cochrane review, across 23 RCTs, not a single one integrated a quality of life measurement. And this is deemed by our PPI focus groups as the single most important outcome that we need to pay attention in future clinical trials. All of this comes with a cost, and the cost of stent insertion, removal, and dealing with complications can total up to £18 million per annum. And this all led us to submit an application into BAUS Dragon's Den last year. This competition was won by Nikita Bhatt, and since then we've been working very closely with the CHART Clinical Trials Unit in Aberdeen. This next two slides is just to give you a flavour of the sort of trial we're proposing. This would be a multi-centre superiority RCT across 25 sites and recruiting 520 participants. We selected the primary outcome to be the pain domain of USSQ, and this is a stone-specific patient-reported outcome measure. Lastly, we'll also integrate economic evaluations as well as a qualitative component. This flowchart gives an overview of the study design. There's just two key points I want to raise. The first one is that we will be performing randomization during the procedure. And the advantage of that is it will reduce surgeon bias. And secondly, we're also performing patient blinding, which hasn't been done before in any previous RCT. And given that we're now using patient-reported outcome measures, that'll give us the benefit of reducing patient bias. So lastly, I'd like to acknowledge everyone involved in this project, and then I'll hand over to Mr. Darren Smith to introduce our first speaker.
Well, good afternoon, and great pleasure to be sitting here as part of the BAUS collaborative, subject very close to my heart, and amazing to see how it has developed over the last 20 odd years. As we all know, there's only one thing that's more valid than a randomized controlled trial, and that is a brilliantly conducted Twitter survey. So I did one of those earlier in the week, and gloriously, with three options of in an uncomplicated ureteroscopy, would you always stent, never stent, or sit on the fence? Equipoise was magnificent, 18% in favor of no, 18% in favor of yes, and a staggering 64% not quite sure. There's only one thing that's more powerful than a brilliantly conducted Twitter survey, and that is a magnificently conducted hands up in the room survey. So with only two choices now, this was like an auction, two choices, okay, hands up for who would never stent in an uncomplicated ureteroscopy. Vote now. 32%. And hands up for who would always stent in an uncomplicated ureteroscopy. 32% as well, and the rest of you are still not sure, which was not part of the rules. Who will follow the rules are the two XX chairs, me being the X chair, so it's rare to get three together. And to start the debate with no further introduction, Dickie Dickinson.
Can I have my first slide, please? Thank you for inviting me first. Friends, endourologists, countrymen, guests, lend me your ears. Is this a stent I see before me? Is this the winter of our patients' discontent? To stent or not to stent? That is the question hopefully we will answer. I'm Andrew Dickinson. I'm a consultant urologist in Plymouth. I had one declaration of interest, and I was the chair of the NICE guidelines, so I'm slightly biased towards NICE guidelines. Good debates always start with evidence. And as we just heard, there isn't a huge amount of evidence, and when we went through this in the NICE guidelines, it's of poor quality. But I'm going to discuss the NICE evidence in a lot more detail, but if you look on this slide, we screened at over 1,600 papers, and yet we only found 17 that were suitable. Very similar for the Cochrane review. They screened 2,631 papers and included 23. And the two things that they found were that pain increased if you had a stent and your operation time increased if you had a stent. But what did we find in NICE? Well, it's all about stone-free, isn't it? That's the most important thing. Well, there is absolutely no difference between stenting or not stenting on your stone-free rate. It's about readmission. There is a slight favour towards the stent on readmission, so you readmit slightly less. But if you actually look at the figures, the number of patients involved is tiny, so you really can't draw strong conclusions from that. The Cochrane review basically said unplanned return visits to emergency were great, there was no difference. And in an observational study done in Michigan in the States, they suggested if you put a stent in, you are much more likely to arrive at the emergency room. There is no difference with major adverse events between stenting and non-stenting. There is slightly more fever in the unstented patient. But again, it's very small numbers. If you want to give a patient stent symptoms, you put a stent in. And that was the concluding thing. All stents cause pain, and it doesn't matter what the stent symptoms are. Every single stent symptom was found to be worse for stents in the NICE guidelines. So, the summary, there is no difference in stone-free rate. There is no difference in length of stay. There is no difference in readmission. There is no difference in adverse events. But if you want to put a stent in, you get stent symptoms, you increase the operation time, and it's not cost effective. There was only one study we found in NICE, and that shows that if you put a stent in, it's more. So why stent? Jonathan?
So, here goes. I wanted to see if I could justify this argument quicker than this artist could paint this picture. So let's see if I can. Here he goes. Dickie's been defending this position since he was young. He's held this position for a very long time. And he's quite right. There are lots of studies out there. Studies from 1999, 2001, 2003. And this 2003 study I want you to focus on, because the title is Routine Stenting After Ureteroscopy for Distal Urethral Stenting is Unnecessary. Is unnecessary. That's what was published in the Journal of Endourology, 2004. But a meta-analysis in 2011, at that point, when all these studies were saying don't stent, at that point, 65%, now we know from other studies, 92% of us still choose to stent after a ureteroscopy because we know that it's safe. And you've just heard Dickie dismiss a little bit of fever. A little bit of fever. 150 patients die a year of stone disease. And patients coming in with a diagnosis of cancer know that they may die. But patients coming with a diagnosis of stones don't think they're going to die. But we know 150 patients a year die of stone disease, 80,000 episodes a year. That's about a 2 in 1,000 chance of dying if you come into a British hospital with a kidney stone. And that's what we're trying to prevent. A little bit of fever, yes. 3 to 5% of patients having a ureteroscopy develop a little bit of fever. How's our artist doing? He's doing quite well. The picture is developing. And patients die after a ureteroscopy. I had a stone. Luckily, I didn't need a procedure, and I got away with it. But we know that 1% of patients in a study published in 2007 died after a ureteroscopy. And I'll ask any of you out there whether you want that to be your patient, whether you want Dickie's little bit of fever to be your patient coming back to hospital and dying after his ureteroscopy, because I don't want that to be my patient. If we're going to do a study, let's assume a 0.1% chance of entering ITU. Let's assume that stents protect that by 10%. Study to detect 85% power of the difference. The study requires 2,422 patients to detect that difference. You can see the Shrivastava study had 26 patients in one arm and 22 in the other, but published a stent is not necessary. There's no way they can make that statement from the number of studies that they performed. The meta-analysis is borne out in 2017, 2017, made a very, very clear statement. The unplanned readmission rate after discharge was significantly higher in the unstented group. And the unplanned admission rate is those patients coming back with fever, those patients coming back with sepsis, those patients coming back who may end up in intensive care. Our painter's doing well. He's getting quicker. He's getting quicker. Let's see if I can get this finished. And it's those patients we're trying to protect, trying to keep safe by doing that ureteroscopy. It's interesting, when I sat down and listened to Olivia Traxler today, I sat down next to another urologist, and I told him what I'm doing this afternoon. And he said, oh, whatever you do, always put a stent in. If you don't put a stent in, you're definitely going to regret it. So Dickie's been defending this argument since he was like this. He's been defending it since he was like this, and no doubt he'll be carry on defending it when he looks like this. We're just going to keep going with our lovely artist. He's doing pretty well, isn't he, drawing this picture? And with ureteroscopy, my problem with ureteroscopy is you don't know about whether it's going to be a complicated procedure until it may be too late. You think to yourself that everything's going well. You're finishing off your piece of artwork. You're finishing off your beautifully conducted ureteroscopy. Trouble with ureteroscopy is you don't know whether everything's okay until everything is finished. Thank you very much.
So quick rebuttals of the other's argument. Not quite enough time to get another aged picture in there. So Dickie, back over to you.
Thank you, Jonathan. Yes, of course, if there is a patient that's septic and you're worried about sepsis, it's perfectly reasonable to put a stent in, but that's not what the discussion is about. It's about the uncomplicated routine procedure. And I think for the vast majority of those, you don't require it. There is nothing wrong with putting in it if it's all gone wrong at the end, but you don't require it for the vast majority. But let's go back to the classics. We had Shakespeare at the beginning. We'll end with the ancient Greeks. Hippocrates. We've all taken the Hippocratic oath. First, do no harm. So, Mr. Glass, we hope you will still sleep well in your bed, immaculate, comfortable, having put a stent in. but the poor patient will not have a good night. And perhaps we owe it to them to give them a good night. Thank you.
Dickie, I have one question. Do you want to be Frank Sinatra wearing this hat? Or do you want to be Dappy wearing this hat? Well, Dickie, you may want to wear this hat because you're going to be Frank Sinatra saying, regrets, I have a few. I, however, am going to be wearing this hat because I'm going to say, ready?
Cut the music. Cut the music now. Enough. So, to round it up from what you have heard, clearly we would say there is a need for a trial. Two brilliant arguments, both faultlessly argued, and yet can we still decide? So we're going to do another show of hands to finish. There's going to be three options this time. In the uncomplicated ureteroscopy, yes, I would definitely stent. No, I would definitely not stent. Or option three, randomize and let the computer decide. So who is going to definitely stent? Still a few. Who is definitely not going to stent? Bit more than a handful. Who's going to let the computer decide? Ladies and gentlemen, we have a trial. Don't forget your props, JG. To both of the ex-presidents, thank you very much for being such excellent sports.
Thank you very much, Mr. Smith and Mr. Burns.
So this takes us to our last talk of the session, which I will invite Eleanor and Hannah to come up and tell us a bit about Rescue, formerly known as our DTORT study, which is our exciting study looking at point-of-care ultrasound in testicular torsion.
Great, hello everyone. We need a little bit of tech support for this one because we want to use the live poll. So if everyone can take out their phones, and on the app for the BAUS conference, if you click into this session, there should be a live poll. So I hope that works, because when I tried to find the tech team earlier, they were having a nice extended lunch break. So welcome to the Rescue trial. A little bit of background we'll come on to, but we would quite like to have the opinion of everyone in the room of how they deal with diagnosing suspected testicular torsion. So if we can have the first poll question. This is, how many scrotal explorations have you done in the last 12 months? So hopefully we can let the poll go live. Oh, it's working. Oh, great. Great. Okay. Right. Perfect. Okay. So moving on. In my centre, I can access urgent ultrasound. That means results in less than 60 minutes or so to investigate acute testicular pain. And we have options usually 24/7, usually but in hours only. Sometimes it's a bit hit and miss, never, or you're not sure. Okay, great. Next question. Do you use ultrasound in the assessment of suspected testicular torsion? Yes, no, or sometimes? Okay, good. I use ultrasound in the following scenarios, and hopefully you can select more than one. The first is in patients with scrotal pain who you think clinically are at low risk of testicular torsion. Option B are those with scrotal pain who you think are at intermediate risk of torsion. C is those you think are clinically at high risk of torsion. D, late presenters. E, I don't routinely use ultrasound, and F, I'm not sure. Super. So a little bit of background to the rescue study. This was first presented at this very meeting in 2018, where Simon Morton presented the results of a multi-center audit looking at prospective data over six months, 116 scrotal explorations, and found only 20% of those patients actually had a testicular torsion. So arguably 80% of those patients had an operation that they didn't really need. And when you put this to patients, they say in this day and age when diagnostic imagery has come on leaps and bounds, it's really unacceptable to be doing an exploratory operation just to get a diagnosis. So what about ultrasound? This systematic review of over 2,000 patients showed the sensitivity and specificity to detect torsion at 86% and 95% respectively. But a subgroup analysis looking at newer ultrasound scanners showed the results to be much better at 95% and 98% respectively. So maybe ultrasound is a useful tool, but the criticism of ultrasound is the delay that it introduces for the patients with torsion to get to the operating room. So what about point of care ultrasound? And what about if we, as the assessing clinicians, do it ourselves as part of our clinical examination? So there's this study from Toronto in Canada, where 120 children presenting to the emergency department with scrotal symptoms had an ultrasound. And in the hands of the emergency physicians, there was 100% sensitivity to detect testicular torsion and 99.1% specificity. And what's more, the point of care ultrasound was done on average 73 minutes sooner than a formal departmental ultrasound. So moving on to rescue.
So this is our proposed study. So we want to recruit all patients that are above the age of 1 year who you have already made the decision to take to theatre for suspected testicular torsion. You will be able to exclude those patients who you think that including them into the study will introduce a dangerous delay to the actual operation, and those with undescended testis and previous scrotal surgery will be excluded. But this study will not change management at this stage. What we want to do is we want to collect baseline data, collect the clinical data, get the clinician to perform the point of care ultrasound, and then the surgical findings. We will also be collecting data on health economics, and then an optional qualitative interview will be offered to participants as well. After a pitch to the Royal College of Surgeons, we were thrilled that then IHR proposed this and submitted a commissioned call on the subject. And we are delighted to announce that we have progressed through to stage 2 of the funding for this. So so keep your eyes peeled for updates from our side. From the training point of view, we have devised a training package which is 3 parts. So BJUI learning module, which they are kindly providing free to access for pan specialty. So we will be including investigators from across different specialties. We are going to design an interactive webinar with interactive cases where you will be able to ask questions and looking at example cases and videos. And finally, with a hands-on local mentorship at your hospital with either a sonographer or a radiologist before being awarded a study-specific certification. We are delighted and very grateful to the Urology Foundation to have awarded us a grant in support of this training package. And I just wanted to say a quick thank you to Canon and Medi Scientific, who have provided the Phantom and the ultrasound kit as well, which you'll be able to play with at the end of the session. Finally, I just want to say a big thank you to the wider rescue team. So we've got a lot of people on board and have been working very hard behind the scenes. But a particular thanks also to the wider expert committee who have been providing their guidance throughout the planning process, and that has got us to this stage. So before we close, we have a couple of final questions we'd like to ask you. Now that you have heard our proposal, would you be willing to complete the scrotal training as described? Yes, no, possibly, or need more information? 100%. Can we make sure we have a photo of that slide, please?
Oh.
Okay, next question. Would you be willing to recruit patients to the rescue study as described? Yes, no, or maybe? Excellent. Well, thank you very much. And I'd just like to end on a on a thank you again to all our sponsors, to Tough, BJUI, Canon Medical, MediScientific. Thank you very much. And before we close, please remember we have Aisha at the back. So Aisha, over to you.
We'll just, before we go on, does anyone have any questions for Eleanor or Hannah regarding the rescue study? Yep. We need you to use the mic.
Just wait for the microphone. Yeah.
Can you hear me? Yes, can. Hannah, excellent. Eleanor, excellent. Many congratulations on the funding. I'm sure you've thought about it and talked about it a lot, but the exclusion criteria of under 1 and the age at which respective hospitals and people feel comfortable doing scopes of explorations in young boys. Could you talk us through why under 1 was decided upon?
Yeah, you can go for it.
Yeah. The pathophysiology is a little different. You've got intra and extravaginal torsion. There's also concern about the diagnostic accuracy of ultrasound in children because obviously their testes are smaller, the blood vessels are smaller. Being able to pick up blood flow in a small testis is harder. Also, in infancy, you've got a wriggling child. It might just be harder to physically perform. We had to choose either we include everyone or we have this cut off. And after lots of discussion with our advisory board and study steering group, that's the cutoff we decided, rightly or wrongly. We wanted to make it as inclusive as possible because obviously we want the results to be as generalizable as they can be.
Just to add to that, we will be performing sub-analyses on the prepubescent group, and we will be looking at specifically Tanner's stage to identify them, and it'll be very interesting to look at the accuracy as in post-pubescent compared to also prepubescent, and so we are looking to assess that as well.
Thank you. Any more from the floor? Obviously, we've got lots of registrars here who might be interested in participating. Can you maybe tell them how they'd be able to contact you in due course and what email and things to use?
So step 1 is for us to secure funding. So that's for us to worry about. So watch this space for news in 2023. Our email address is rescue@bursturology.com. You can contact us through the website, through Twitter, through to me and Eleanor directly. We are starting to keep a list of people who've expressed an interest in being a collaborator on the study. So if you're keen, do let us know and we'll make sure we keep you updated.
And does it matter if they've got high volume or low volume centers or?
Ideally, if you're working in a high volume center, but it's difficult, isn't it? Because we move all the time. So who says you're in a high volume center one year, you might not be the next year. My message is if you're interested, get in touch and we'll find a way to make you involved.
Okay, thank you, Hannah and Eleanor.
So now we have some hands-on sessions led by Aisha Azam, who's a radiology registrar from Guy's and St. Thomas's at the back. Obviously, this is a very large group. We're going to hang around into the kind of coffee break. So if some people want to go up, if some people want to go and come back. Aisha, you have got a little kind of talk you want to give, but I think that's while you're demonstrating.
Okay, and we've also got some slides that are going up of different kinds of pathology, so you can get the idea of what you might be seeing when you do your scrotal ultrasound scans. So if I hand over to Aisha.
I don't know if is my headset working? Okay, yeah. Perfect. If you guys would all like to come towards the back, and then we can go through testicular ultrasound. Hello, welcome. Come, don't be shy. Okay. So yeah, for those that won't be able to see, then you can have a look on the slides. They'll sort of hopefully be rolling throughout the platform. But okay, I think we've got a big enough crowd. A couple more minutes. Okay, just a few more. Okay, I'll start. So just to introduce myself, I'm an ST5 radiology registrar at Guy's and St Thomas's Hospital, and I specialize in neuroradiology. So I'm going to just talk a bit about the basics of testicular ultrasound. Unfortunately, because we're using a phantom here, we won't be able to go into looking at Doppler flow, which is obviously critical in torsion, but it's to give you a taster of simply how easy it is and what the anatomy is like so you can familiarize yourself, okay? And after I've done my quick talk, which will be very quick, I want you guys to get your hands on the probe as much as possible, okay? And have a go on what it's like and ask me as many questions as you like, all right? So, what is ultrasound? So essentially, ultrasound is whereby we use a transducer to emit sound waves which pass through tissues. And as they are reflected back, the returning wave, the echo, is interpreted by the machine to form an image on the screen. So I'll keep it as basic as that. We need, obviously, to use quite a lot of gel. And as I do this, you'll be able to see on the monitor that this then is displayed here. So this is this nice thick gel layer, which we can use as our interface between the tissue and the probe. So the most important thing when you do testicular ultrasound on a patient is to position them in the right way, okay? So they need to be supine, laying down, and ideally you need to either get the patient to, first of all, hold their penis against their abdominal wall, so that is out of the way, and normally you put a drape of tissue over here, so that gives them a bit of privacy. Then you can either ask the patients to bring their legs together so that the testes rest on top, okay? But sometimes if the patient is in too much discomfort or has mobility issues, that can be not possible. So the alternative, which I recommend, is to scrunch up a big ball of tissue, okay, and just put it underneath. That's really important because testes are really mobile. They just sort of go everywhere, and you really need to have a firm basis to perform your ultrasound on, okay? So positioning is really important. And obviously, patients in pain as well can be a whole separate factor. So the first thing I do after I've put the gel on is I need to orientate myself. Normally on the probe, there'll be a marker of which way around you have to hold the probe. And sometimes on transducers, you also get an indication, a marker that corresponds to a signal, sort of a marker on the screen as to which direction you're looking at. We don't have that here. So the best thing to do is just simply use your finger to touch the edge of the probe. And as you can see, I don't know if everyone can see, but we can see that edge here. So that is my right edge. So what do I first do when I'm doing testicular ultrasound? I, first of all, have the testes like this and just take a transverse picture. Sorry if I'm blocking your view, but this is what we call the sunglasses view. You can probably understand why that's called the sunglasses view, but that is really important because you need to be able to compare the right and the left testes. This gives you a really nice snapshot of exactly, is there any asymmetry? Is there any gross abnormalities? It just gives you a nice perspective of what's going on as a whole. So sunglasses view is always what you should do first of all. And then just as in your clinical examination, I would start with the asymptomatic testis, so the normal testis, okay? this is really important for you to get an idea of what is normal. Every patient is different. The degree of color flow on their testes is going to be different. So you need to work out what is normal for the patient. Obviously, you do get dual pathologies, but we're sort of keeping it simple here. Okay. So I will start with the right testes. So